Thank you, Dr. Herndon. And again, as he said, I'm going to be talking about DISH today, or diffuse idiopathic skeletal hyperostosis. I'm going to refer to it as DISH so I don't tongue twist myself too many times. But essentially what this disease is a calcification of the ligaments that are attached to the spine. So the things that are usually there to protect and kind of relieve some of the stress of the spine actually get hardened and ossified. Another name for the ligaments that are attached to the spine, they're called the entheses, which I'll talk about a little bit more when we start talking about diagnosis and how we go about diagnosing DISH. As Dr. Herndon said, another name for this is Forster's disease. And interestingly enough, it seems to have a pretty high incidence. However, with that high incidence, there's only a small subset of those patients that actually go about developing symptoms of this disease, which can be stiffness, pain in the back, and I'll talk about that a little bit more a little bit later on. But it is a relatively common disease, just most patients don't even know they have it because it doesn't cause any symptoms or any problems for them. So when talking about DISH, I want to talk a little bit about other types of back disorders that could resemble DISH or are similar to DISH. So the first one, which we've all probably heard the radio ads about and different things about, is ankylosing spondylitis. So what is ankylosing spondylitis? Essentially, when you have this disease, you have stiffness and pain in your lower back. It typically starts in your lower back, but it can migrate upwards towards your upper back. In severe cases, it can affect the joints and it can cause them to fuse together, which you can see in the picture on the slide, to actually cause severe back stiffness, which makes it very hard for patients to move and get about. It can also affect areas outside of your back. So it can affect your hips, your chest wall, even your heels. So there's a lot of places where this can affect. And this is a little bit different than DISH, and then this seems to be more autoimmune or have to do with rheumatologic disorder. As with DISH, and I start talking about the pathophysiology of that, it is quite a bit different, even though the end result is similar. Another type of spondyloarthritis is reactive arthritis. So reactive arthritis causes pain, swelling, and inflammation of the joints. And the big thing about the reactive arthritis is it typically causes problems in the sacroiliac joints, which you can see listed here, and some of the more exterior parts of the body, such as the toes, fingers, and feet. In this condition, you also may have swelling of the digits or the fingers, which are termed sausage digits, which you can see here in the picture. Some other unique things about reactive arthritis that can happen is you can have weight loss, a skin rash, which you'll see a lot of these SPAs can present with skin rashes, and of course inflammation. Then we have psoriatic arthritis or psoriatic arthritis, and this one's usually in patients that have psoriasis. So typically when we think about psoriasis, we think about that skin disorder where you have almost sloughing of the skin that's happening too quickly or happening at a faster rate than would typically happen. So as far as psoriasis goes, it's not, as far as psoriasis and psoriatic arthritis, at least the correlation, it doesn't appear that there is a correlation with severity of psoriasis and the risk of psoriatic arthritis. So it can pretty much happen to any patient with psoriasis, independent of how bad their actual like red scaly patches are or how bad their actual disease is. So in this disorder, you also can have toenails and fingernails that show pitting, thickening, yellowing, and you can also get what you could call like a sausage digit in this disorder as well. So in this disorder, you usually have the larger joints, such as the hips and sacroiliac joints, much like reactive arthritis, that are affected. So enteropathic arthritis is another one that is another spondyloarthritis. And this one usually happens when patients are having inflammation of the intestinal wall. In this condition, the symptoms typically come and go, but it really has a high incidence in patients with inflammatory bowel disease. It's estimated that 10 to 20% of patients with IBD or inflammatory bowel disease will develop some kind of enteropathic arthritis. And this, again, typically affects the large joints. So it can be your hips, your ankles, your knees, your elbows. It usually affects some of your larger joints in your body. And then there's the undifferentiated. So this essentially is a term used to describe the signs and symptoms of spondylitis, or a spondyloarthritis condition. However, it doesn't meet any of the diagnostic criteria for any of the actual conditions. So the reason why I bring these up is because a lot of times when we have patients with back pain, we're going to have to figure out what is the cause of their back pain. We're going to have to exclude some things before we can say, this is definitely the cause of their back pain. Because with a lot of these conditions, since a lot of these are autoimmune, we can use monoclonal antibodies and things to treat them. However, with DISH, with the pathophysiology of how that presents, it's a little bit different, and we probably don't have the same treatment options as we do with some of these other conditions. So what are some other causes of diffuse ossification of the spine? So fluorosis, or essentially getting too much fluoride. So this is a very rare condition. It has been documented in the English language several times in literature, but from what I could find, it was about a half a dozen times that this has been documented. And it's a very rare form of ossification that really happens most often of the ligamentum flavum. And right now it's a pretty rare condition, but it's usually from taking too much fluoride in. One that we might have more say-so in or understanding of is actually long-term retinoid therapy. So what does this mean? Okay, this is your isotretinoin. This is your Accutane. This is a lot of times those medications that are given to patients that have acne that has failed first, second, third line treatments. We know that these medications have a lot of risks with them, such as pregnancy, birth defects, and things like that. But what they're finding is that long-term retinoid therapy has been shown to potentially cause vertebral hyperostosis in patients. The reason behind this is believed to be the fact that the retinoid therapy, or like isotretinoin or Accutane, is very similar to vitamin A. And what has been shown is high doses of vitamin A can actually help to induce a diffuse ossification, especially in the spine. So this is another thing to think about. If a patient has been on Accutane long-term, especially multiple sessions of Accutane, they do increase that risk of having diffuse ossification of the spine. Another one we probably learned about in school, but don't see too often anymore, is acromegaly. So we think about the Alton giant. We think about people that are very large because they unfortunately have too much growth hormone. Now, typically we have treatments for this, and this doesn't happen anymore. So it's not as common of a condition. We'll typically see people with really large faces, and okay, there's probably something going on. Nowadays, we can treat this condition, so it's much more rare cause of diffuse ossification. We also have oncrosis, which is a metabolic disorder caused by the accumulation of homogenistic acid in the connective tissue. So what this essentially does is cause a yellowish discoloration of tissues when seen on microscopic examination. But again, it's kind of rare. And then we have some more, some other genetic cases of it, and then achondroplasia, which is essentially saying dwarfism. Patients that have dwarfism are at an increased risk for diffuse ossification. And when I say dwarfism, I say that achondroplasia is the most common form of dwarfism. Now, there are other conditions that have different names that can lead to dwarfism, but when patients do have achondroplasia, they are at that increased risk for DISH, or diffuse ossification. So typically spondyloarthritis, I'm not going to get into this too much because it's not really the purpose of my talk with like ankylosing spondylitis and things like that. But typically how we can treat these are with rheumatologic agents, so like TNF alpha antagonists. So here we think about like Humira, Enbrel, Remicade, Simponi, some of these monoclonal antibodies, which can help to prevent the progression of these diseases, even though it's not going to reverse them. Second line in these conditions, NSAIDs, which is going to be pretty much our first line agent for DISH. I'll talk about it a little bit more when we go on, but we're going to want to start like we do with any pain condition. We're going to start with the adjuvant analgesics and work our way up depending on the patient's symptoms and what's going on with them as a whole. So when we think about who is at risk for developing DISH? Since we don't know a whole lot about the pathophysiology, it's important to realize that there are some risk factors that predispose patients to be at a higher risk for developing this disorder. The first one is BMI. It has been shown that patients with an increased BMI, especially the overweights or greater than 30, have been indicated or have been shown to have an increased risk for developing DISH. Another one, which is a big one, is metabolic syndrome. So especially patients with type 2 diabetes, patients with type 2 diabetes have been implicated in development of DISH. Now, that doesn't mean that just because you have type 2 diabetes, you're going to develop this disorder, and it does not have as strong of a correlation with type 1 diabetes, but it is shown that metabolic syndrome and type 2 diabetes both have a increased incidence of the development of DISH in patients. And the last two, male. So males are more likely to develop this syndrome by about 3 times. And then age. You'll see here, this is one study that looked at the incidence of DISH per age. And you can see as you age and get older, the incidence actually does go up, which does make sense. I mean, this is a back disorder, and typically we think about back pain and things getting worse as we age. And this is no outlier. This is also within that group. So they've actually looked at DISH versus ankylosing spondylitis. And what is the difference? Because when you really look at them, they're both characterized by new bone formation in the spine. But when you really try to dig deep and figure out, okay, what's the difference between diffuse idiopathic skeletal hyperostosis and ankylosing spondylitis? It seems like the pathophysiology is about how they get to the end point is where they really differ. So the reason why I chose these two is that there's a good study assessing and comparing these two, but also the two most common forms of ossification of the ligaments and tendons in the axial skeleton and the peripheral sites. So what are some differences? So typically with these, the formations of new bone are found at the anterior site of the vertebrae. So they're not on the back side or the posterior side of the vertebrae. They're actually on the other side of the vertebrae, so more towards the front. In both cases, thoracic spine and upper part of lumbar spine are the most frequently involved areas of the diseases. So they do typically involve the same parts of the spine, both DISH and AS. Now, both spinal inflammation and new bone formation occur in ankylosing spondylitis, but we're not exactly sure how they're related to each other. It is believed to be an immune-mediated inflammation, which is why we use those TNF-alpha antagonists to help treat ankylosing spondylitis. But when you look at DISH, it's different. It's most frequently assumed to be a characterized disorder of metabolic abnormalities, which is why we see that increased incidence in type 2 diabetes and when patients have metabolic syndrome. Unfortunately, I couldn't find any data to support, does improving diabetes improve DISH or slow it down or prevent the progression? I couldn't find any studies assessing that, but if you think about it mechanistically, and if we really think that it's characterized by the metabolic abnormalities, that could be an avenue of potential treatment of treating that underlying diabetes to help prevent the progression. But as I said, there's no study, so this is all just speculation. So what else was looked at? So in this study, they also looked at AS patients versus DISH patients. They included a significant amount of each, so 140, which is relatively good for a pain study. And they looked at what the difference actually was. And they found there are some differences as far as the number of bone spurs and the number of syndesmophytes. So the syndesmophytes are essentially the areas where liquid can kind of travel through the spine. This is one of the areas that actually can harden. So we see that there is a significant number. And as far as x-rays and determining the progression of these disorders, they both seem to progress similarly. So it was speculated that one might be worse than the other as far as the progression goes. They were actually expecting ankylosing spondylitis to be worse, but what they found is over time, they actually both progress in a very similar fashion. One thing that was found is that in ankylosing spondylitis, they were found to have more syndesmophytes. So you can see here 5.7 plus or minus 5.5, while the DISH patients only had 2.7. So you can see there is an increased risk for syndesmophytes, or the number of them. On the other hand, though, DISH was found to have more degenerative bone spurs, or essentially bone growths or ossifications. And you can see here 1.4 plus or minus 1.8. So both of them were statistically significant as in the diagnostic findings, but as far as clinically what that means, we're not exactly sure about which one or if any of those actually have a clinical aspect. So now the pathophysiology of DISH. How does DISH happen? So it's characterized, as I said, as ossification of the ligaments or the entheses of the spine. So the entheses are essentially the bones, the attachments of bones to the ligaments and tendons of the spines. And it was believed that entheseal inflammation was the reason why we developed DISH. But it appears that it's not required in the development of DISH. So when looking at patients that are on the way of developing DISH, or we've actually done studies to look at subgroups of patients before they actually had DISH and looking at MRI findings, and then looking later on, okay, they did develop DISH, so their retrospective studies. But what we find is before these calcifications actually harden and turn to bone, they actually become fatty. So they become a fatty infiltrate that actually infiltrates those tendons and ligaments as opposed to inflammation. There have also been recent studies that have looked at the entheseal inflammation and ossification, and they found that they're independent of each other. And what I mean is that they do not affect bone, or they do not affect newborn formation. So how do they do this? They essentially took mice, they injected them with the steroids, dexamethasone. And as we know, as long-term steroids can decrease bone growth. And they looked at these mice over 12 weeks. And what they found is, well, for one thing I didn't mention, is these mice were diagnosed with DISH, or they genetically made them predisposed to DISH, so they were expecting to have DISH. What they found was, interestingly enough, is that bone growth throughout the mice's body was decreased. So the bone mineral density, the inflammation, all of this was decreased. However, the bone formations of the entheseals and the ossifications of the spine did not decrease at all. So even though their whole body had reduced bone capacity and was not building up as much, as far as the bone growth on the spine, that continued to grow. So this is one way of looking at, okay, is it really the inflammation of the spine that causes this and the bone growth, or is it something else? So there's still a lot of research going into how this actually happens, but we do know it is somewhat unique as far as other back conditions like ankylosing spondylitis. So now the fun thing, how do we diagnose it? And as I said before, at least the studies indicate that a number of elderly patients do have this disorder, but they don't have any symptoms. So it doesn't cause any problems. It's not problematic, and they may never know they even have this symptom. But the first thing that someone's going to do if they do have this symptom, or the easiest way to diagnose it, and really the one used most often, is a typical radiograph or an X-ray. So in this case, you can actually see here these bony growths on the anterior part of the spine. And you can also see flowing syndesmophytes between the spines here where they were actually growing. So to actually diagnose DISH, you have to have at least 4 vertebral bodies in a row. So you'd have to have 4 bodies that are connected in a row. And when you really think about it, you have to have some other things too, which I'll talk about a little bit on the next slide when we actually look at some diagnostic criteria. But other than X-ray, so this is the first line, and this is probably one of the gold standards of, okay, they have DISH. All these other things I'm going to talk about are typically more for exclusion. Okay, do they have some kind of spinal cancer? Do they have metastases? So it's a lot of times when we use some of these other diagnostic materials, we're using it more as exclusion as opposed to actually diagnosing the disorder. So the next one is a computed tomography or CT scan. And these are not typically indicated in DISH. Typically, there would be no reason to get one of these if you are worried about DISH. Really, the only way that these are going to be beneficial is if you're trying to evaluate for something like a fracture or spinal stenosis, or if they are having the complications of DISH. And one of the complications of DISH, which a CT scan could be beneficial for, is to see if they're putting pressure on the esophagus or the inferior vena cava. One of the problems with DISH, and it is relatively rare, but it can cause dysphagia or problem swallowing and problem speaking if it does happen in the upper parts of the spine. And a CT scan can help differentiate where this is happening and how much pressure is actually being put on the esophagus, which could cause this dysphagia. The next one is MRIs, which can be beneficial. Now, they're not typically indicated because typically plain radiographs or x-rays can get the job done in determining if they do have DISH. However, an MRI can be beneficial in some cases. And really, when we'd use this is when we're trying to determine the extent of ossification and the presence of spinal cord compression. So if they're having pain that's going down their legs, if they're having signs and symptoms of neuropathic pain, we can use MRI to see, okay, are there discs being compressed? Is there some kind of compression going on somewhere? And what is the actual extent of ossification in the spine? Now, there's some other things we can use. Nuclear imaging, we typically will never use. It's really never indicated in this condition. And then PET scanning or positron emission tomography. And this is the one where you'd really look at to differentiate, okay, is this a metastatic vertebral deposit or is it a metabolically active osteophyte? And the way that we can use this PET scan to determine that is that if it has a really high metabolic rate, and you can tell that by PET scans, typically it's going to be more likely a metastatic vertebral deposit, which can be sucking up all these nutrients. However, if it's just a metabolically active osteophyte, it's going to have a much lower metabolic rate than if it's a metastasis from cancer. So doctors can use that to differentiate or to exclude cancer versus just a metabolically active osteophyte. Any questions so far? I'll check the chat and see if I can, maybe. Well, I can't see the chat. Okay. So essentially they're having diagnostic criteria outside of these different diagnoses that we can look at to help diagnose DISH. Now, these aren't the only two criteria. The Resnick isn't the only criteria, but I want to kind of compare, okay, how do we diagnose DISH versus how do we diagnose ankylosing spondylitis to help differentiate the two when we're looking at these patients that really could have either one. So when patients have DISH, as I said, they have to have 4 adjacent vertebrae that all have these ossifications on them. There has to be a preservation of intervertebral disc space, because if that would happen, okay, maybe it's ankylosing spondylitis, maybe it's a different condition. And then the big thing is absence of the apophyseal or really the sacroiliac changes. So as I mentioned with some of those other conditions that likely affect the sacroiliac joints or the joints in the hip, DISH typically doesn't. So if they do have these changes, more than likely it's going to be some other type of condition outside of DISH. Now, when diagnosing ankylosing spondylitis, typically it's going to be similar to DISH. We're going to have the same symptoms and things like that. But really the change is that there's going to be changes in the sacroiliac joint. Now, does that necessarily mean it's AS? No, it could be one of those other conditions that I had mentioned. But likely that's going to be the differentiating criteria to differentiate DISH from ankylosing spondylitis. Okay. So what are some associations with DISH? So patients that have DISH, what is different about them than patients that don't have DISH? And what we're finding is that there's definitely some changes in these patients. They have some elevated serum levels of some hormones. So growth hormones are typically elevated. We also have elevated insulin levels with insulin like growth factor 1. And both of these were found to be independent of BMI or diabetes. So as we know, sometimes with diabetes and other conditions, we can try to ramp up our own insulin production, even though it's not sensitive and it's not going to work. But what we're finding is these were independent and these were pretty much strictly associated with DISH. Now, whether the growth hormone and IGF-1 led to DISH or the opposite, the DISH led to these, you can't really say, but we have found that these levels are increased in patients that have DISH. And as I mentioned before, some of the risk factors that increase DISH, so diabetes is one of them, and then type 2 more often than type 1. And then we have hypertension. So hypertension and diabetes go hand in hand, but patients that have hypertension are also at that increased risk for development of DISH, and then obesity as well. You can see here, there was one study performed that looked at, okay, what kind of patients are more likely to develop DISH. And you can see here, even though diabetes was non-specific in this case, or was non-statistical, other studies have shown that type 2 diabetes does increase that risk. But you can see both high blood pressure and metabolic syndrome in this case were statistically significant, as well as waist girth. So it's going to be something to look at in these patients to see if they meet these criteria, to see if they are at that increased risk for the development of DISH. Another interesting thing this study found, which I thought was very interesting because I hadn't made the connection, but patients with DISH are at an increased cardiovascular risk. So this study was done a while ago, but it was essentially because they use the Framingham score. They don't use the new ASCVD risk. But what they found is there is a statistically significant increase in 10-year cardiovascular risk in patients that have DISH, which would be this first number, versus patients that do not, which would be the second number. So what I'm saying here is that even though it is a back condition and really mortality, morbidity is not affected in this condition for the studies, they are at the increased cardiovascular risk. Now, is it because they have metabolic, or they're more likely to have metabolic syndrome and hypertension and type 2 diabetes? Likely. It's hard to say that that's not playing some impact, but still, it's something to think about in patients that do have DISH. So what are some complications we see? Now, one of the, I would say, a worrisome complication and a very potentially traumatic complication of patients is dysphagia or airway obstruction. So they're not able to talk very well, they're not able to breathe, they're not able to swallow pills, they're not able to drink water, and this is caused from compression of the esophagus. So if these bony growths happen in the upper parts of the spine, they can actually cause pressure on the esophagus, which can make some of these typical things that we do, like swallowing, very hard. If patients have this severe enough, they can undergo surgery, which can be used to help restore normal swallowing and breathing, but there are some problems. And I would say the biggest problem with surgery is that 40% of patients experience dysphonia. So they weren't able to talk either loud enough or they weren't able to talk the same way that they had talked prior to surgery. And then about a quarter of patients had residual dysphagia at 6 months. So you're looking at almost half the patients after surgery have some kind of complication with talking. And then a quarter of patients still have dysphagia 6 months later. So even though surgery can be beneficial, it can still have a lot of complications, and especially in this group of patients, which I'll talk about a little bit. Obviously with DISH, we're going to worry about back pain. I mean, you're having ossification growth in the back. However, when looking at the actual severity of pain, they have looked at back pain associated with DISH versus back pain associated with osteoarthritis. And what they found is typically patients with osteoarthritis rated their pain as higher than patients with a DISH, which is interesting because, I mean, it was an interesting find that I could see. And I was like, well, why would that be? I didn't really understand why. And the authors did have some reasoning as why they think it might be. They speculate that since DISH causes the bony growths and can actually induce some spinal stiffness, it could actually be protective against pain. Now, I read this in several studies that DISH could actually be more protective than non-protective, in that preventing uneasy movements, and really the stiffness could be protective, but that's still something that I think needs more studies. Another problem with DISH that commonly occurs is vertebral fractures. And I shouldn't say commonly occurs, but it is something that does happen in patients with DISH. And the reason why we know that likely it's due to the DISH is that about 60% of the time when patients have vertebral fractures and they also have DISH, it's along one of those vertebral bodies that has been ossified. So the vertebral fracture, the fracture line, is in one of these vertebrae or discs that actually has been compromised by the DISH. So another problem with this is that these vertebral fractures aren't from people falling off roofs typically. They're not from going on a plane and jumping off a plane without a parachute and say, oh, hope I don't get hurt. It's typically from patients that are falling from a standing height. So not a dramatic fall, not falling down the stairs. It's typically just a small fall that would actually cause this to occur. And then we also can have peripheral involvement. So this is a complication typically of the spine, or at least it starts in the spine, but that doesn't mean that it can't travel to the periphery, because the periphery also does have enthesophytes, And then these peripheral enthesophytes can also lead to bony growths. That can happen in the shoulders, the elbows, and some of the hand and finger joints as well. So how do we treat DISH? Unfortunately, data is lacking major on this condition. Much like some of the other back conditions that are more rheumatologic, we can use NSAIDs. Now, has data been have we looked at using things like rheumatologic agents, Humira, and things like that for this condition? I couldn't find any studies on it, but really looking at the pathophysiology and the speculated reasoning behind it happens, I would assume that it wouldn't work because it doesn't seem to be an autoimmune disorder. It seems to be a metabolic disorder that I would anticipate that improvement in diabetes would help, but I think more studies need to be done to really assess that. Or if they've already been done and I missed it, that's always an option as well, or a potential option. And then we have step-ups therapy, essentially. So muscle relaxants, if it's not being controlled, moving up to opioids and going from there. Now, obviously, if we're going to be treating with opioids, we're going to want to be good clinicians, make sure they're trying to reduce the risk of diversion, abuse, misuse, etc. One thing that has been studied in the treatment of DISH is physical therapy. So there was one study, it only had 15 patients in it, but they underwent, I would say, somewhat severe training with mobility, strength training, and stretching for 24 weeks. So this was a relatively intense program that they went through. But what they found was that over half the patients, so 8 patients out of the 15, showed good improvement in their DISH signs and symptoms after that 24 weeks. The study didn't go on to look at how long these effects lasted, but it did show over 50% of patients did have improvement from daily strength training, stretching, and mobility training. Now, like I said, this is a very stringent program if you're going to be training every day for this, but I think physical therapy does have a place in the treatment of DISH. And kind of one of the last things I want to kind of talk about is surgery. So can these patients undergo surgery? And if they do, is it worth it? So Atsuki and colleagues had actually looked at this question and said, okay, what is the risks of doing a lumbar fusion in patients with DISH? So they looked at 208 patients and they categorized them by either having DISH or not having DISH. So these patients would have been candidates for lumbar fusion. And what did they find? They found that patients with DISH had, I don't want to say more complications, but they did worse off than patients without DISH. You can see here by the results that almost 20% more required additional surgery if they had DISH. I mean, a quarter of the patients that underwent this lumbar fusion required additional surgery, while only 1 in 20 or 1 in 18 of the patients without DISH required additional surgery. That's kind of a big deal. You can see the hazard ratio for the DISH requiring additional surgery is about 5 times. And you can see by the P number that is very statistically significant. And I would also agree clinically significant as well. And then depending on if they had a 1-level fusion or a 2-level fusion, so this is with the DISH patients, that also increased their risk for that additional surgery. Again, statistically, and I believe clinically significant again, but if they had a 2-level fusion, they had about a 3 times more likely risk to have to undergo another surgery than if they only had a 1-level fusion. So I would say as far as surgeries go, I wouldn't recommend it unless the patient absolutely needs it. Because if you think about how this condition actually works, I mean, your tendons, your ligaments that are in the spine turn to bone. And if you're cutting them open and you're manipulating different things to the spine, is that going to turn into bone instead of scarring over and things like that? There's a lot of questions, a lot of problems, but we do know that patients that undergo especially back surgery with DISH have worse outcomes, and it's really not going to be recommended. On the flip side, if they're having problems swallowing, problems breathing, and it's very problematic for the patients, affecting their quality of life, that might be a better indication for undergoing surgery to relieve some of that pressure on the esophagus to make them able to swallow, especially if they're not able to eat and they're becoming cachectic or problems like that. That might be more of a reason for surgery. But really, I don't think it should be indicated in most patients with this condition just because of how these tendons and ligaments actually turn to bone in this condition. And unfortunately, like I said, we don't have a whole lot of good data to support pharmacologic treatments. There's not one good agent. I mean, it's going to be trial and error, and likely if the patients have it bad enough, we'll have to step up to opioid therapy and just be good clinicians and making sure we're monitoring everything we need to with the opioids. So that is my talk on DISH. So I will open it up to anyone that has any questions.
So Dr. Rea, I think it's important to share with our audience today the reason that this topic came about. We actually have a retired military patient who has awful chronic pain in his a lot of the smaller joints in his feet, his ankles, as well as in his knees. And I think he also has some pretty significant chronic low back pain as well that we really have very little that we can offer him due to this disorder based on at least our previous understanding. So I guess that's my statement, and my question would be, after doing this presentation, Brad, is there something that we're missing that we could be offering this guy?
Chris, I don't really know. I mean, I don't know if he's tried physical therapy be an option. Obviously, surgery is kind of off the table unless it becomes super severe. But this is one of those conditions that just doesn't have a whole lot of good data about how we go about treating it. I really don't know what else we could offer him. If you have more insight, something that I'm missing that I'm thinking about, I mean, unfortunately, if it gets bad enough where patients show symptoms of this disorder, then it becomes, a big problem for treatment. Now, as I said, a lot of patients have this disorder and have no symptoms, no signs, and it's not really a problem. They live and they most likely pass on with it without ever knowing they had it. But when it starts to show signs and symptoms, it becomes, are NSAIDs even really super beneficial if it's going to be the fatty deposits that calcify instead of like local inflammation? It's hard to even say. I'm not really sure what else we could do for our patient.
Yeah, I don't. We've had him managed on relatively high dose opioids for so long. We tried weaning him down to see if maybe there was a hyperalgesic component to it. But I feel bad for that gentleman.
Yeah, it's not a fun condition. Seems like all these talks are never fun. Pain is not fun. It's maybe fun for us, but patients in pain is never fun. So, any other questions from anyone? Let's see. Oh, thanks, Julie. Okay. If that's all, then thank you guys for your attention. And anyone that's in the IC areas, please be safe today.
Okay, thank you so much, Dr. Rea. And once again, the recorded version of this webinar will be available for access on the member portal for the Society of Palliative Care Pharmacists. And please stay tuned for next week's topic to be determined. Thanks so much and stay safe.